stabilizer. Okay, guys. And usually asked in your theory and viva, and very, very important. And even your for clinical practice. Okay, as we know, it in periodic table, it is the third element, lightest metal. And before coming to the pharmacokinetic mechanism and indication, first look how it evolved and the history of lithium. Okay, so if we see the chemical discovery, Mr. John A discovered a lithium. Okay, then the another name that you should remember is Alfred B. Garrod. Why? Because he used lithium for the treatment of gout by the hypothesis that lithium dissolved the urate. Okay, so this era is called gout area, and Mr. Alfred B. Garrod are the first one who use it for the treatment of gout. Okay, so remember this name. Then we have William A. Hammond. He is the first person who used lithium in a management of person with psychiatric illness. Which illness? Mania. But due to his toxic side effect, he didn't continue it and didn't do any RCT or anything. So, but the first person, if we remember the name, William A. Hammond. Okay. Then there are Lynch brothers. Okay. They uses lithium for the depression. Which one? Melancholic depression. But again, because of the toxic side effects, he discontinued. And between the 1894 to 1949, there is a huge gap, and this gap is known as forgotten area. Why? Because people got scared that lithium is good, but it has too many side effects. Okay, so they did no further studies, trial has been done. Then our hero, Mr. John F. J. Cade, is here. If you think this is history is too much, you have to remember just one name. Which name? Mr. John Cade. Okay, he's the one who uses lithium in the management of mania, and he first treat 10 psychiatric patient, and his study show positive improvement. Okay, then we have Morgan Shu. Why his name is important? Because he is the first one who did the RCT. Okay, so like I said, only one name if you have to remember, Mr. John Cade. And what is it? Some examiner do ask, what is the full name of Mr. John Cade? Okay, so Mr. John Frederick Joseph Cade. And he is Australian psychiatrist. And some people even asked, in which year? 1949. Okay, so history of every, especially the classical drug, are very important. Okay, so while working on lithium, firstly, the research hypothesis of Mr. John Cade was that mania is happened because of intoxication of body product. Which product? Uric acid. So lithium, he considered lithium will dissolve that. So he inject urine of many patient in a guinea pig and consider that many patient has something in the body that is very toxic. Okay, while doing that, he used lithium urate, which is a more soluble form to decrease toxicity. And by when he inject lithium urate, he found that guinea pig become more calm and lethargic and less aggressive. So then he discovered that lithium has calming effect. Okay, and for human safety, he himself take the lithium. Okay, then into the many patients. But if we consider who did the proper RCT, then Muggins. Okay, that's why these 3 4 names are very important. But if you consider this is too much, just remember Mr. John Cade. Okay, this is very important. Then, so first we discuss the history, then pharmacodynamics and pharmacokinetics. If I asked, can anyone tell me what is the mechanism of action of lithium in mood disorders? Just guess. No one is judging you, just answer in the chat box, please. How lithium works? whether it is in mania, depression. If any one of you attended the previous lecture taken by me in any course, I hope you will answer it. Or even in CTP, there are 5 mechanisms are given. Shijan, second messenger system, okay. Neuroplasticity, daisy good. But Shijan with secondary messenger system. Replacing with sodium, okay. And how it will act? Very good, Shijan. How will it will act by replacing with sodium in mood disorder? Pranjali? Okay, one is secondary messenger PIP3 and EAG, second is neuroplasticity, third. At least give me 5, na? Then we can PKC. So PKC stimulation or PKC inhibition? Alienist, batao jaldi. Inhibition. Very good. Then the cousin sister of PKC. Answer. Lithium also inhibit GSK3. Very good. It also act on apoptosis process. So tell me, it is anti-apoptotic or pro-apoptotic? I helped you. So GSK3 inhibition, PKC inhibition. Next apoptosis mechanism. So just tell me what lithium will do. Someone tell na neuroplasticity. So how it will uh, help in neuroplasticity? Shijan? अरे जल्दी जल्दी बताओ. गेस ही करना है. वाइवा में एग्जामिनर ऐसे पूछेगा. फटाफट 5 मैकेनिज्म बताओ. Regulation of gene expression. Okay. Like we need some food for our survival. Neurons need some growth factor for survival. Name the most common growth factor. Necessary on for BDNF. Very good. It increases the level of BDNF on the long-term administration. It's common for both lithium, valproate. That's why recent hypothesis is going on that lithium has role in management of Alzheimer. Okay, because of its neuroprotective action. It increases the level of BDNF. Okay, it's anti-apoptotic. Okay, so it will help in regulation, survival, and growth of neurons. Okay, so revise with me. You guys already tell me, then we will discuss it again. First, neuroprotective, we know all the 3 things. Then secondary messenger, someone told PKC inhibition, GSK3 inhibition. Okay, another thing, if lithium do some anything with the neurotransmitter, the previous hypothesis was neurotransmitter only. So let's see this table. A very beautiful book, potential mechanism of action of a chapter, CNS drug, in which this is the chapter. And I take 2 diagram from this and it is very beautiful. So lithium act in this layer, okay? If you see, what will lithium do to the mood? See, it decreases the mania and long-term mood stabilization along with decreased suicidability. What it will do with the cognition? It will alter cognitive functioning. Okay. In structure, it is a neuroprotective. It will increase global gray matter, amygdala, hippocampus. Okay. If we see the effect on the neurotransmission, so it will increase the inhibitory neurotransmitter such as GABA and decrease the excitatory. That's why it help in the management of mania, the neurotransmitter theory. And the recent hypothesis, and everyone is very interested, is the cellular intercellular. So remember these 5 hypotheses. Modulation of neurotransmitter, we know. Secondary messenger, we know. Okay, PKC mark, inositol depression. Then antioxidant defenses, anti-apoptotic, like I discussed now, and neuroprotective action. How? Increase the BDNF level, BCL2 level, which is also anti-apoptotic. So remember these five and tell them. So because of this, neuroprotective action, cognition improved, and ultimately this. This is the simplest version. Is it clear? So we can go deeper down in the molecular version. Okay. Is it clear, guys? This is very important, especially for your viva. Okay. Even for your rounds, you should know every single detail about the lithium. Shijan and everyone, batao jaldi. Is it clear or should I repeat it again? अरे जल्दी जल्दी रिप्लाई करो. Yes, clear. Okay. Ipshita. Okay. No issue, Ipshita. So see, if we see the effect of lithium from micro to micro level, what will lithium do? We know it has effect in the management of mania, depression. So it has anti-suicidal load and mood stabilizer. That's why we give in the prophylaxis of bipolar. If we see the cognition, it altered the cognitive functioning. Okay, it's a neuroprotective. Okay, and help in the neuroplasticity. That's why recent evidence are saying that lithium can be used in the Alzheimer because of its neuroprotective action. It enhance cognition. Okay, how it will influence the structure of neuroanatomical structure. It will increase the global gray matter, amygdala, hippocampus, prefrontal cortex. Then if we see neurotransmitter, what it will do, it will calm down. So the CNS depressant, inhibitory neurotransmitter will increase and the excitatory like glutamate is decreased. And the one of the most important thing are cellular mechanism. We know neurotransmitter. Then it will have action in secondary messenger system like protein kinase, MARC-CK, okay, and decrease the inositol level. Okay, so secondary signal transduction are impacted by lithium. Third, it has antioxidant defense. So it will prevent excessive oxidation, free radical injury, and anti-apoptotic action. So, and neuroprotective BDNF level, it will increase. So ultimately, lithium will help in neuroprotection, neuroplasticity. Okay, so regulation of the neuron growth, survival of neuron, and prevent is apoptosis. So that's why lithium has role in it. Ipshita, it is clear. Now we can go in detail about the molecular mechanism, how it impact the secondary messengers transduction. Okay. See, these are the receptor. These are the receptor. A neurotransmitter bind here and the secondary messenger pathway started. Okay, how it started? There are secondary messengers like CAMP, IP3, DAG will release and with further progress. And there's a role of protein kinase C and GSK3. These protein kinase and GSK3 will further increase the signal transduction and lead to the overall impact. So what will lithium do? It will inhibit this. Okay, and when it inhibit this, the secondary signal transduction hampered. Apart from this, it will increase the BDNF level and BCL2 level, which will prevent the apoptosis and promote the growth. Okay, and in this, lithium is also decrease the level of inositol, which is also involved in the secondary messenger. Okay, so remember, inhibit the PKC and GSK2, increase the BDNF and BCL2, and decrease the inositol level. If I say for valproate, it is also similar. So if you remember this, same mechanism go with the valproate. Valproate is also neuroprotective because of increase of BCL2. Valproate also decrease the PKC inhibitor and GSK3 inhibitor and also decrease the inositol level. It's same for lithium and valproate, this molecular mechanism. So my next question for you, if you guys are aware, any PKC inhibitor recently used and very well promoted by marketing agent? Yes, Shashank. Very good. Endoxifen. Is it FDA approved to use in any condition? So, PKC inhibitor, endoxifen. Very good. Manic episode. Okay. Off-label is used in various conditions, like one of manic episode. Another indication off-label for impulsivity, aggression in elderly patient with dementia. Yes. Emotionally unstable personality disorder. Okay. So off-label it tried in many other condition and there are various case reports, trial has been going on or this, but not FDA approved for any condition. So if examiner asked whether it is FDA approved, so this is the latest drug. So after we cover the mood stabilizer, there is another lecture. A special lecture will be taken on endoxifen for detail by Dr. Manish. Okay, in which we detail each and every aspect with the recent update. And it is very necessary, especially for the exam going batch. Okay, now we have seen this up. If we see the lithium, like I said, some mechanisms are similar for lithium as well as valproate. Okay, so ma'am, is that aggression in elderly dementia? Yes. Shashank Makarala, yes. For the management of aggression in the elderly person with the dementia, it is used to decrease the antipsychotic load in the patient. Even it is used in the management of delirium. Okay, so in elderly we want कि antipsychotic load हम कम करें. Because if you give antipsychotic to prevent the side effect, you give THP, that is also worsen the cognition. Okay, and these elderly are prone to have antipsychotic induced side effect. So endoxifen is, let's see how it goes, but seems to be promising agent for the management of aggression and impulsivity in patient with the dementia. Okay, so let's see. This is also a diagram from that article only, which shows the use of various agent in mood disorder and where they act. Like we see, antidepressant usually act by receptors, and on the long term administration will also of antidepressant will increase the BDNF level. That's why it was advisable if person have multiple episode or two or more episode, the duration of treatment should be 2 years at least. Why? And you see the patient will have improvement in their concentration, attention, cognition at very last. Why? Because it will take time to increase the BDNF. Okay, BDNF is what? Protein, na? So for to create more protein, it will act as a cellular level. So by 6 month therapy, it will not benefited. So you have to take antidepressant or give antidepressant for at least 1 or 2 years to increase the BDNF level, to have neuroprotective effect, to improve attention and concentration. Okay, so that duration that was given in various guidelines are based on this factor. Okay. If BDNF is increased, there will be neuroprotection. So there will be less chances to have the relapse. Okay. So this is the logic and it is very important. Now see, we have, this is our agent. Lithium, lithium, lithium. It inhibits the PKC. It inhibits the GSK3. See, and ultimately it will help in mania and depression by neuroprotection, neurogenesis, synaptic plasticity. Done. Is it clear? अब इसके बाद याद रहेगा ना सबको हाउ लिथियम वर्क्स. नहीं तो मैं दोबारा रिवाइज कराऊंगी. बोलो. सृजन, शशांक, प्रकृति. इज इट क्लियर? आगे चलें. ओके. If we clear with the pharmacodynamics, another important thing for lithium is pharmacokinetics. Okay. कृष्ण रिपीट करेंगे. चलो एक बार आखिरी बार रिपीट कर देते हैं. Lithium, how lithium act by the cellular mechanism. See, this is lithium, na, the green one. It will inhibit the PKC, GSK3, which are secondary messengers protein, which will further increase the signal transduction. So, when lithium inhibit these proteins, then signal transduction stop. Okay. Then lithium also act by decreasing the inositol level, which is also a secondary messenger. Then another mechanism, it will increase the BDNF level, increase the BCL1 level. BDNF is growth factor, BCL1 is anti-apoptotic factor. So this way, because of this, it will help in the survival of the neurons, regulation of their growth. Okay. In neurotransmitter, it will increase the GABA, decrease the glutamate, and also help in prevention of free radical injury. This is so simple. Just remember these 5 points and this diagram. So in psychiatry, while writing your exam, you don't have to mug up too much summary theory. Just remember few classical diagram, few classical flow chart, and you're good enough. Okay. So अब हमारे पास बहुत कम टाइम है. अब फार्माकोकाइनेटिक्स पढ़ते हैं फटाफट. तो लिथियम फर्स्ट फार्माकोकाइनेटिक्स में हम क्या पढ़ते हैं? एब्जॉर्प्शन, बायोबिलिटी, मेटाबॉलिज्म एंड देन एक्सक्रीशन. ओके. So see, absorption, it is rapidly and completely absorbed, and for the peak, it is different for immediate release and controlled release. For immediate release, peak is fast, 1 to 1.5 hour. For controlled release and SR, 4 to 4.5 hour. And if we see the bioavailability, unlike other agent, it has no plasma protein binding. This is very, very important. So now my question is, which two mood stabilizer have highest plasma protein binding? And these are very classical one. Lithium is an exception which has no plasma protein binding, and because of this it has no interaction with that mood stabilizer. That is a notorious mood stabilizer which has carbamazepine. No, very good decision. Valporate. And valporate and another one. Valproate has very classical interaction with another mood stabilizer because of high plasma protein binding, which is the second one. अरे बताओ. Lamotrigine, very good Ipshita. So see, यहाँ पे लिख लेते हैं Valproate plus lamotrigine. Classical interaction है इनका because of high plasma protein binding. Okay, So what valporate will do, it has high plasma protein binding and high affinity. It will displace lamotrigine from glycoprotein, and because of which the lamotrigine level is increased in blood, leading to side effects. That's why when you're giving these drug together, you should start with the low dose and optimize very gradually with the very low dose increment. So this is very classical interaction because of plasma protein binding. So you have to remember it. I will repeat it again when we study valporate. Done. This is important. That's why I kept it here only. Okay. If we see the metabolism, unlike valporate, lamotrigine, carbamazepine, which are actively metabolized by CYP enzyme, lithium is an exception which have no active metabolite. Okay. So this is another important Viva question. And it will excrete out by mainly by kidney and little amount by the sweat and feces. So it excreted unchanged in urine. If you have to remember 5 points about pharmacokinetic, remember the peak. Okay. Second, it has no plasma protein binding. It has no active metabolite. It's exchanged unpassed. Major excretion is by kidney, and the T half is 18 to 24 hour. Okay. This is why this is important. And even why T half of any drug is important. What it will help. Yes, ODBD dosing, guiding dosing, steady state, peak plasma level. So dosing schedule. Okay. So another important aspect for special cases तो करेंगे, is pharmacokinetic changes happen in the pregnancy. Okay. So we see the lithium clearance is increased. GFR is increased in the pregnancy now because of increased inner blood flow. So lithium clearance is increased. So the blood plasma level of lithium is decreased by the end of second trimester. So you have to look for the serum levels and increase the monitoring frequency. And during delivery, suddenly this vascular volume, which is increased during the after the second trimester, is suddenly decrease. Okay, and suddenly the plasma level increase. So you have to remember these pharmacokinetic changes in pregnancy. Okay. Then there is pharmacokinetic changes in elderly. What will happen? Can anybody answer? What change in our elderly people? How it will impact the level of lithium? Anyone? Increase GFR. Very good. Ma'am, can you repeat the pregnancy changes? So Shashank, what will happen? Okay, so what will happen? Neuroprotection for dementia. That is good. GFR is so first discuss pregnancy, the doubt. In pregnancy, first thing, vascular volume is increased in the body. Second, the lithium clearance is increased because GFR is increased, renal blood flow is increased. When clearance is increased, so plasma level decreased. Okay, but suddenly after the delivery, there is a sudden blood loss. Baby is out, placenta is out, there is so much blood loss. Suddenly the volume, blood volume is decreased and GFR is come to the normal, which is increased previously. So suddenly the plasma level of lithium is increased. Okay, Shashank, now it's clear. In elderly, the GFR is decreased as compared to young adults. So, clearance is also decreased. So, there is more risk of side effects or toxicity. So, you have to be very careful when you are giving lithium to elderly people. You should start at low dose as compared to a young adult and monitor more frequently. Shijan, can lithium be used in first trimester, ma'am? That will depend on the patient profile. I will discuss this question after end of this session when we discuss the effect of lithium in pregnancy. Okay? So, after we completed the pharmacodynamics, we completed the pharmacokinetics. Now, what are the psychiatric indication? We know in mood disorder, bipolar, it used in the and it is FDA approved for the management of mania. Okay, so it is a first line antimanic, although its action is slow. It will take 1 to 3 weeks of treatment. Its onset is slow as compared to which one? Which mood stabilizer used in mania has more rapid action, onset of action as compared to lithium? Valporate. Very good. So this is the question lithium you can give, but you should wait for at least 1 to 3 weeks. For during that time, what will you give? You just not give lithium. You should also give adjunctive therapy or benzodiazepine and antipsychotic during the acute phase of mania. Then we have acute phase of depression, bipolar depression. It is also used, but it is not FDA approved. It is used off-label. Then, can anybody tell me which psychotropics are FDA approved to use in acute mania? There are 3 mood stabilizer and 4 antipsychotic. So, which mood stabilizer? One we know lithium. Second, olanzapine is antipsychotic. Okay. Quetiapine, good. Valporate. Okay. And another mood stabilizer. Carbamazepine, olanzapine. Okay. Another antipsychotic. One start with R, one start with Z. Are risperidone. Don't forget that, na? And ziprasidone. And one that is not written here is aripiprazole. So, Kitri, what happened? You write stop. Okay. So, my next question is this question is mentioned in your CTP. Consider a person is on lithium therapy for the management of bipolar as a prophylactic agent. Have a breakthrough episode. What will you do? What will be your next step in the management? So, just give me what will you do as a clinician. You started one patient on the prophylactic treatment of lithium for the management of bipolar, but she had a breakthrough episode. So, what will be your next step? Okay. Check blood lithium level. Okay. Add low dose. Add antipsychotic. Consider dual mood stabilizer. Arey, first thing is you have to evaluate why this breakthrough episode happened. Very good, Shijan. You said right. You should check what about the compliance, about the adherence. You will inquire about the compliance by taking history from the family member or close one. Then you can also go for a serum lithium level. Second, like someone till now, you go for the recent stressor good thyroid profile. And another thing, डिहाइड्रेशन से तो बेटा टॉक्सिसिटी होती है ना अंकिता, ब्रेक थ्रू नहीं होता, है ना। सब्सटेंस, वेरी गुड सृजन। ठीक है, दिस इज इम्पॉर्टेंट। सो फर्स्ट चेक सीरम lithium level, compliance, TFT, and substance abuse history. Sometime patient don't give history, family member are not aware, so just go for a urine tox skin. That can happen. So for this, we will learn about drugs interaction and drugs that decrease the lithium level. Okay, so that's why history is very important. First, you have to evaluate. Never say, I will add antipsychotic. Arey, first, you have to evaluate what will cause this breakthrough. Only then you will take any action. Na? So, evaluation is always the first step. Then you will do anything. So, why hypothyroidism causing breakthrough? There is psycho, neuro, endocrine hypothesis of bipolar disorder. Okay, which we will discuss on later on in detail in neuropsychiatry lecture, but those have attended code red already aware about this. There is impact of various hormones, thyroid one also, pituitary hormones, six hormones, which impacted the various neurotransmitters and has role in the course and outcome of various disorder, and one of the important one is a bipolar. So hyperthyroidism can alter the course of bipolar disorder and can increase the frequency and increase the severity of the episode of any manic depressive episode in the bipolar patient. So this is a very broad topics which we call psychoneuroendocrinology, but that is very important. Okay. And how it will another, why more in females? So मुझे बताओ, अभी हम साइड इफेक्ट पढ़ेंगे ना, देन वी विल रीड हाउ लिथियम विल कॉज हाइपोथायराइड ए पेशेंट कम इन एक्टिमेनिया विदाउट एनी RFT. Can we start lithium immediately without knowing the renal function? Then you should also take the history and you should also see the patient profile, whether patient is young adult, older adult, whether patient is has diabetic, hypertension, on any other medication, whether patient has substance history. Okay, consider a 70-year-old male with history of diabetes since 20 years and on metformin for so long, and also have hypertension in last 30 years. So you already know if patient is having diabetes, hypertension, definitely his kidney function is compromised. So you will not start, na? You will go first all routine checkup. But if a healthy adult, a young adult come with no medical history, okay, then you can go. So it will depend on the patient profile. So like I said, there is a topic called course and outcome of bipolar disorder, which we cover in adult psychiatry. So there are factors which have role in course of bipolar disorder. And one of the important one is substance abuse, medical conditions, compliance. There are other factors which will increase the frequency and severity and the duration of episodes. So, the course of bipolar is dependent on various factors, which we read in adult psychiatry. Okay, this is a big lecture. Done, Rahul. Then we all know lithium is FDA approved for the maintenance therapy as prophylactic agent in bipolar disorder. It will decrease the frequency and severity of episodes. Done. So, in bipolar, we have seen the role in the mania, depression, and as a maintenance agent. If we see a unipolar depression, how lithium will help? It is used off-labelly. Am I audible, guys? So, it is used off-labelly in unipolar depression also, and it is, yes, okay, Shashank, it will also help in a patient with having suicidal ideation because it has anti-suicidal effects. So now it's my question to you. Which are the psychotropic agent have anti-suicidal action? One is lithium, we know. Psychotropic agent and psychosomatic treatment. Okay, close up in, very good. Okay, so we have lithium, we have clozapine. Okay, so we have lithium, clozapine, ECT, and one of my favorite, ketamine therapy. Okay, recently ketamine clinics are going on for the rapid management of person with depression, which is who is actively suicidal. So, ketamine, don't forget that. This is important Viva question. Lithium has also role on schizophrenia and schizoaffective disorder, which is used off-labelly, not FDA approved. Then it is also used in aggression, independent of its mood stabilizing action. And because of this, it is also used in person with intellectual disability. Okay, for its emotional instability and behavioral discontrol and self mutilation. Okay, so these are psychiatric indication. Now, with apart from psychiatric indication, you guys will tell me what are the non-psychiatric indication. This is another Viva important question and usually asked during the rounds. Epilepsy, very good. Then, अरे फटाफट बताओ, at least 10. Leukopenia, very good. movement disorder, dementia, and so what lithium do as a side effect is hamper the thyroid function. It will cause hypothyroidism. So its side effect can be used as a treatment also. Thyrotoxicosis, very good Ankita. And अरे जल्दी जल्दी बताओ. Lithium is previously used for one condition. It will dissolve gout. Very good. So let's see. Historically, it was used for the gout. Okay. Epilepsy, headache, movement disorder. Okay. Even for tardive dyskinesia, Tourette, in hematological, aplastic anemia, chemotherapy induced leukopenia. Okay. Drug induced neutropenia. Then in endocrine, thyrotoxicosis. In dermatological, genital. And okay, the recorded version will be only available for the student that those enrolled for the final strike. Okay, so others please attend it live. Then in gastrointestinal, it is used in the cyclical vomiting, in respiratory for asthma and cystic fibrosis. Migraine is another important indication. So you can remember by remembering the system: endocrine, CNS. So lithium also lower the seizure threshold. And why it is used in epilepsy? Lithium also have neuroplastic effect which will help in management of epilepsy. Clear? So see, the long term administration of lithium cause the also action on on sodium channel. So lithium don't have any action on the sodium channel. So what will body do? We will see in the side effect profile of the lithium. Body confuse lithium with the sodium. It will not inhibit or stimulate sodium channel. Body confuse lithium with the sodium channel. Sodium. So when lithium level is less in our body, sorry, sodium level is less in our body during fasting or vomiting or any dehydration. So what body wants? It want to have more or more sodium in the body. So when lithium is available, body also started accumulating lithium and started reabsorption. So in dehydration, lithium level is increased. This is the interaction between lithium and sodium. I am repeating it again. Lithium have no impact on channel. Body confuse lithium with the sodium. When there is loss of sodium and water during dehydration, diarrhea, vomiting, fasting, body try to have more sodium. So when lithium is available, body confused that it is also a sodium. It will increase its reabsorption and gradually the level of lithium is increased, which will lead to the toxicity. That's why you psychoeducate patient while giving lithium for the treatment that don't fast during dehydration. If you are having these symptoms, please report and maintain dehydration early. Why body confuse lithium with sodium? अरे सबसे पहला चीज क्या है? दोनों कौन से ब्लॉक को बिलोंग करते हैं? लिथियम इज थर्ड एलिमेंट, सोडियम इज विच एलिमेंट? दे बिलोंग टू द सेम ग्रुप ना. एस ब्लॉक होता है गेस. यस, दे आर बिलोंगिंग टू द सेम ग्रुप, दैट्स व्हाई. हम्म. सेम पीरियोडिक ग्रुप, वेरी गुड. ठीक है, अब याद रहेगा ना. अब ये किसी ने गलत करा तो वर्चुअल पिटाई. ओके. सो नेक्स्ट थिंग, what is the strength available? This is very important question asked by the examiner. And you should also know for your clinical practice. For immediate release we have 150, 200, 250 and 300. For control release we have 450 and 400. These are lithium, which formulation? Carbonate. And it is also available in syrup form, which is lithium citrate. So 5 ml of lithium citrate syrup have 3 milligram of lithium citrate, 300 milligram, which is equivalent to 8 milliequivalent of lithium. Can anybody tell me any brand name of lithium? You should know at least 5 brand names. लिथोसन, लाइकैप, और बताओ. लिथोसन तो सबको पता है, लाइकैप भी पता है, अब बताओ. आई वांट 5 at least. Okay, 4. 450 Intalith. Very good. Okay. Escalate. Very good. So our HOD used to ask these question. If you don't know the even brand name and you're confused with the strength, definitely he will scold you very badly. So you should know these basic strength available and brand name and even the cost. Okay. So before starting lithium, there are some pre-treatment tests. Lithium has side affecting the kidneys. That's why you have to see kidney function test. If already impaired, you should not give lithium. Then thyroid function test. Then ECG, and in the pregnant female, you should also go for a urine pregnancy test in a female belonging to reproductive age group and baseline weight. Okay. Now, sorry, we have to go very fast. We are already late. This class supposed to be 40 minutes. So we have two regimen how we start. Okay. As per Mosley, we start with a single HS dose, 400 milligram for 7 days. Then we do serum monitoring and you increase every 7 days till the desired serum level is met. Okay. This is as per Mosley. But as per CTP, it was given that you started with the divided dose. Okay. Then do a serum lithium level and you optimize every 7 days. Okay, until desired level is seen. So as per Mosley, start with the OD dosing. As per CTP, start with the divided dose. So whatever regimen you are doing in your hospital, just give the reference also. We are answering as per that reference, CTP, Mosley, or anything. Okay. While on therapy, remember you will do lithium serum monitoring, kidney function test, and TFT every 6 monthly. Just remember one digit, that is 6 monthly. So you don't need to repeat serum lithium level every month. So why you are wasting resources? So if patient is maintaining well, you have to repeat the serum lithium level every 6 monthly. But in some condition, you have to do it immediately. Even 6 month time is not met. What are these conditions when you do serum level sampling? Just give me one or two answer. Pregnancy. Okay, but something more emergency condition, guys. Toxicity. Consider a patient come to your emergency with the sign and symptom of lithium toxicity and the history suggestive that he had done some self-harm ideas, having suicidal ideation, he takes some pills, and there is a history of lithium given in the treatment chart. You should get alarmed. It should be lithium toxicity and start the treatment. Also send the serum lithium level toxicity. Then if patient have breakthrough episode during maintenance therapy or history of non-compliance and during pregnancy. Done. Remember this. So you do serum monitoring. So first see how to do it and when to do it. Serum level should be sent 12 hours after the last dose after achieving the steady state. And it is achieved after giving lithium for 5 days as given in CTP and 7 days as per Mosley. Okay, so remember 12 hours after the last dose after the steady state is achieved. Okay, so usually the morning time sample is given, and what we measure in it, serum trough level. And how it is measured by, it is measured by flameless atomic absorption mass spectrometry. Just remember the name. And we measure a trough level after the achievement of steady state and after the 12 hour of the last dose. Remember this. Okay, let me finish it, then I will answer alienist. Okay, first thing, the serum lithium level, the therapeutic drug monitoring. So I will take all the question at the last. We are already late, guys. Okay. So therapeutic range as per CTP should be between zero point 0.5 to 1.5. Intoxication we said more than 1.5. Mania 1 to 1.5. And maintenance 0.6 to 1.2. Okay. Acute main as per Mosley. For maintenance we are try to keep zero point 0.6 to zero point 0.8. This is what we practice. Okay. So if your answer, the therapeutic drug monitor range for lithium for maintenance is zero point 0.6 to zero point 0.8. For mania 0.8 to 1. For depression 0.6 to 1. Okay. So 0.6 to 0.8, 0.8 to 1. Maintenance and manic episode. Remember this one. This is what we practice. And this is as per Mosley. Okay. So whatever you answer, do give a reference. That is very, very important, especially in your Viva. So what are the side effects of lithium? If we see in CNS, there is impaired attention and concentration if you're giving high dose, and during toxicity also there is tremors. Initially there is memory impairment. Initially in CVS there is tachy. Okay, there is increased risk of arrhythmias. In urogenital, what will lithium do? Anyone? Polyuria. Most common morphological side effect is interstitial fibrosis. This is also important. If dermatologically, it will cause acne. Okay. In GIT, what it will cause? GI upset, nausea, vomiting, diarrhea. So the GI side effect are the earliest one. In hematologically, what will it do? It will increase the WBC level. Okay. So next, there is a child come to your clinic, pediatric clinic, with this type of X-ray, and there is a history of a mood stabilizer intake by mother during pregnancy. leading this condition in the child. What is this? Abstain anomaly. So in this we have acne, we have hair loss, and if a pre-existing dermatological condition like worsening of psoriasis or any other pre-existing condition. Okay. So this is abstain anomaly. So teratogenic side effect of lithium is abstain anomaly, which is a serious disorder, and incidence rate is anyone? 1 to 2%. It belongs to FDA category D. So if we see all the mood stabilizer belonging to category D, only the lamotrigine belonging to category C. So if we see the teratogenic side effect, lamotrigine has minimal along with the oxcarbamazepine, which is similar to the normal population. For valproate neural tube defect incidence is 1 to 5%. For carbamazepine, 0.5 to 1%. And lithium, we know 1 to 2% for Epstein anomaly. So just remember this. Okay, guys. Now see, drug interaction. The important thing is ACE inhibitors, diuretic, NSAIDs. These three you should know. Okay, if you don't know this, is there any other drug that can cause it or it can occur spontaneously? I don't get your question. I am saying abstain anomaly can happen in anyone because of other developmental disorder, na? But it is also reported that person, if a pregnant female take lithium during the first trimester, there is incidence of 1 to 2% of having the Epstein anomaly in a child because it will hamper the cell migration. It will hamper the cardiovascular system formation. Okay, especially the cushion. So Epstein anomaly can happen because of other factor, but I am discussing it here because lithium is associated with the Epstein anomaly. Okay, so now we are at drug to drug interaction. Remember, ACE inhibitor, what will it do? It will increase the lithium level and lead to the toxicity. Similarly goes with the NSAID. So you should psychoeducate your patient and evaluate their other treatment history. Like patient is on antihypertensive, which antihypertensive it's on ACE inhibitor. Then you should check the serum level of lithium, or you should change the antihypertensive, or you can also change this agent. Okay, so you should know in diuretics or loop or thiazide, just see thiazide diuretic increase the lithium level and loop diuretic decrease the loop lithium level. So if patient is taking diuretic for any condition like congestive heart failure or worsening of hypertension, so you should also monitor this because it will alter the lithium level. Then we have lithium toxicity. In this, there are sign and symptom of lithium toxicity and how we'll manage it. This is very, very important and you should know this by your heart. We can divide lithium toxicity in 3 stages: mild to moderate, moderate to severe, and very severe. Initially, the GI side effect come vomiting, dryness, abdominal pain. In neurological, there is ataxia, dizziness, speech disturbability, muscle weakness, and patient become very lethargic. So, what will you do? First, you go for a serum level monitoring, maintain the ABC, and you could discontinue the drug immediately. And the first step should be maintain the hydration, maintain the fluid, and electrolyte balance. That is the first priority. Okay, then if the level increase to 2 to 2.5, the GI side effect worsen. There will be persistent nausea, vomiting. The CNS side effect will be more as compared to previous, the blurred vision, this clonic limb movement, conversion, delirium, and patient can even land up into the stupor coma. So what will you do? Apart from the above, water and electrolyte manage, you also do a gastric lavage. And in severe case, hemodialysis is warranted when serum level is more than 4 equivalent. So remember the staging. This is given in same synopsis and CTP. Now we are done with this and the recent update regarding this that I want to discuss and already discussed. Then multiple trials has been going on its neuroprotective effect, warranted its use in the management of dementia because it will increase the BDNF level, increase BCL2 level. Okay, so neuroprotective and neuroplasticity. Second, I'd क्या लिखा? Okay, after relapse along with the for an adolescent BPAD, earlier lithium tolerance. Just let me complete this, then I will answer your question. Okay. So first recent update is neuroprotective action. Multiple trial has been going on, and this is very amazing. I have been following up these trials. Okay. Then second, we have read that lithium will impair the renal function, and we are also monitoring KFT every 6 months. So the question is lithium on long-term treatment can cause CKD? So the answer is yes. Multiple follow-up study has been done and lithium can be associated with the CKD because what will it do? I already mentioned that it will also change the morphological changes. It will cause the fibrosis, which will impair the function, and chronic impairment can lead to CKD, chronic fibrosis. Okay, so you have to keep on monitoring, and if person has already have CKD, even a stage 1 or 2, you will not start lithium. You go for the another agent. Okay, then there is another debate going on whether OD dosing is better or divided one. So the debate is going on still, which one is better. So one of the CNS side effect of lithium is also sedation. And GI side effect are the earliest one, and the most common side effect and the earliest side effect of lithium is GI side effect. Remember this. Most common side effect or earliest side effect of lithium is GI side effect. So those who's favoring for OD dosing are saying that if person belong to working class having reported sedation, so you can give OD dosing in the initial phase as per them at night dose, so there will be less impairment in the daily functioning in the initial phase, because in the initial phase where you are optimizing the lithium level, there is incidence of more GI side effect which will get better on later on. Okay, so these are saying OD dosing, and as the T half is good enough 18 to 24 hour, so there is no need of divided dosing. Okay, but some are favoring OD divided dosing, like give 300 milligram, so the peak will be less as compared to higher dose at single go, so there will be less GI side effect. But the another thing is patient will have sedation or impaired attention and concentration in the morning also. And if we drug has already 18 to 24 hour T half, then why there is any need to give in a divided dose? So the pros of cons of both regimen are there, and debate is still going on. Okay. With this, I guess we are already, yeah, in initial phase, the attention and concentration is impaired and there might be increased irritability, that is true, but it will get settled down. Okay, so that is initial CNS side effect of lithium. So that's why the dose optimization of lithium is happen very gradually after 7 days. In antidepressant, what we do, we start with the 5 milligram or 2.5 milligram of escitalopram. We wait for 3, 4, 5 days, then increase it. Okay. Does lithium interact with the ARB also? So what will ARB do? Alter creatinine level. Beta, like I said, lithium will cause fibrosis in the renal parenchyma. Ultimately, the renal function is impaired. If renal function is impaired, there will be less creatine clearance. So creatine level is increased in the body and there is less excretion of creatinine. You write creatinine or creativity? How lithium affect thyroid? Creativity. Okay. So, okay. I meant creativity. So you want how lithium impact creativity. Good. So beta, initially तो attention concentration impaired होता है. There will be blunting. But later on when patient get better, and if I say, if by giving lithium you are improving the course and outcome of a illness, definitely the productivity of that patient is improved. Okay. Guys, I guess we are already taking so much time. So if you have any more doubts, just put it in the group. And we will also share some articles like the initial ones I used in the mechanism action part. These are very interesting one. So I will share, please go through it. Okay, I hope you guys enjoyed the lecture. Any feedback? Okay, with this, I have few announcement. The final strike. Initially, we have 1 year course. Thank you, Pamlita, Shashank. It's very nice. Ipshita, thank you, beta. Thank you, Hima. I hope you enjoyed. I also enjoyed. I love this interactive session, especially psychopharmacology is my favorite part. Okay, so psychopharmacology is not just bookish way. We interact so we can remember it. Okay, so in final strike, we will do 2 sessions a week on psychopharmacology. I tried to cover whole psychopharmacology before December. Okay, so in final strike, previously we have 1 year program. Then due to students in second year, they said to increase it 2 year program. Now we are having final strike 3.0 for first year residents. So surprise for them is it will also include comprehensive psychopathology course. So these two have rapid revision, which is inclusion and psychopharmacology. I am covering it. In for 3 year program, For first year residents, apart from above benefit, we are also giving comprehensive psychopathology course for 3 years. Okay. So if you have any doubt, any query,